This presentation is an introduction to pressure volume loops and the important physiological principles that go along with constructing these diagrams. Let's direct our attention back to a Wiggers diagram for a normal cardiac cycle, and what we're going to do here is plot pressure in the left ventricle versus volume in the left ventricle. So we're going to start by looking at the mitral valve opening first. Now that corresponds to this spot here on our pressure volume loop. And after the initial Y descent that we see in phase 6 of the pressure in the left ventricle, the pressure and volume are correlated together, positively correlated together, so that we find a increase in pressure with increase in volume. Next, we'll direct our attention to the next step, which is when the mitral valve closes. I'm going to go ahead and mark that over here on our pressure volume loop. Now recall that at this stage, the diastolic filling is now over, and we are now at our end diastolic volume within our ventricle. Now recall that in phase 2 there is a rapid increase in pressure with no change in volume as the valves at either end of the chamber are now closed. So we'll see an increase in pressure with no change in volume. You will perhaps recall that the name of this process is isovolumetric contraction. When the pressure within the left ventricle exceeds the diastolic pressure of the aorta, the aortic valve is going to open up. And what happens initially is a rise in pressure with a decrease in volume as blood is ejected out from the ventricle to the aorta. When we enter phase 4 of the cardiac cycle and the ventricle begins to relax, we're going to see a drop in pressure and a continued drop in volume as blood continues to move out of the ventricle into the aorta. Finally, systole ends, the aortic valve closes, and that is reflected here on our diagram, and the pressure in the ventricle drops very rapidly at a constant volume as, again, the valves on either end of the chamber are closed, so volume will not change within the chamber with this relaxation process. So that is known as the end systolic volume, the volume that this process occurs at, as systole is over and volume isn't changing in what is known as isovolumetric relaxation. One final note is that we can determine the stroke volume with this diagram by taking the difference between the end diastolic volume and end systolic volume, and that gives us our stroke volume. Let's talk now about another concept called preload. Now, the definition of preload is the initial stretching of cardiac myocytes prior to contraction. It's therefore related to the sarcomere length. Now, let's go ahead and take a look at our hearts again and take a look at what this means. We're going to be examining the heart during diastole, and as we will recall, the filling that happens from the atrium into the ventricle during diastole will cause the ventricle to enlarge in size. This will cause stretching of the myocytes. The atrial kick will provide even more stretching onto the walls of the ventricle. The final volume in the ventricle at the end of diastole is called the end diastolic volume. We can therefore see that the ways to measure preload includes, or at least to estimate preload, includes end diastolic volume. Another way to estimate preload is if we pretend that the ventricle is a balloon, and if we insert volume into this balloon, we're going to have a corresponding pressure increase in the intraventricular pressure. And because there is a relationship between volume and pressure, we can use end diastolic pressure as a way to measure preload. Now, this relationship is known as compliance. And in this situation, we have considered a balloon. However, if we have a different situation, such as with maybe a rubber bottle that we're trying to fill, an increase in volume will actually lead to a much higher increase in intraventricular pressure. And that is because the balloon has a relatively high compliance, whereas the rubber bottle has a relatively low compliance. So if we go ahead and graph these relationships with volume on the x-axis and pressure on the y-axis, we will see a relationship between pressure and volume for a high compliant chamber, such as a balloon, but we'll see an even higher increase in pressure for a similar change in volume for a low compliant ventricle. And we should also note that these relationships are not truly linear, as this is cardiac muscle, which is biologic tissue and has structural limitations to its pressure relationship with volume. So, situations in which we see decreased compliance include ventricular hypertrophy, which stiffens the ventricular wall and therefore makes it act more like that rubber bottle. We also might see a decrease in lusitropy. Lusitropy is the ability for the ventricle to relax. So if the ventricle can't relax, we have a stiffer wall and a decrease in compliance. On the other hand, increased compliance might be seen in a chronically dilated ventricle, which easily fills with volume for a small change in pressure. So let's go ahead and summarize the relationships that we've talked about. An increase in end diastolic volume corresponds to an increase in preload. Now, it is noteworthy that preload, again, is a measurement of sarcomere length, and end diastolic volume is a way to estimate the length of the sarcomere. If we were to consider a highly compliant ventricle, we would see that an increase in end diastolic volume would correspond to an increase in end diastolic pressure. But if we were to see a low compliant ventricle, an increase in end diastolic volume would show an even higher increase in end diastolic pressure. So let's go ahead and put this pressure-volume relationship of end diastolic volume to end diastolic pressure into our pressure-volume loop. Now, the area that I have marked out here in red is, remember, the diastolic filling part of the pressure-volume loop. So if we are to extend out this line on the ends, that represents the end diastolic pressure-volume relationship. And again, remember that because this is biologic tissue, it is not linear, especially at high end diastolic volumes. We're going to talk a little bit more about preload, but in order to do so, we need to better understand muscle fiber physiology. So I like to think of muscle fibers as springs. And the reason why is because the more you stretch the fiber, the more recoil strength there is. So this doesn't work exactly with a linear action as springs do, but it is similar in that respect that the more you stretch it, the more it will want to recoil. So let's give our muscle fiber some pull and say that it moves from a certain distance from baseline length for the muscle fiber. This will give a passive tension in the fiber. Now, we also know that fibers receive a ventricular depolarization, and that leads to an active tension within the fiber. So if we were to graph this of tension versus length, we see two relationships. One is the passive tension, which increases with length, and the other is active tension, which also increases with length. Together they make a total tension. Now, it's important to note that while passive tension makes sense with increasing length because there's more recoil with that increase in length, the active tension has to have some other underlying process which makes it stronger with increase in length. So that is a result of likely three mechanisms that make what is known as length-dependent activation. A first possible mechanism is increased troponin sensitivity to calcium as the length of the fiber increases. That will, of course, increase our susceptibility of myosin to bind to actin and increase the strength of our contraction, as well as the speed of our contraction. We also might see increased calcium availability by altering the homeostasis of calcium within the cell, and thus a greater affinity and greater binding of calcium to troponin. Finally, with increased length, we see decreased diameter of muscle fibers, and that might improve the interaction between actin and myosin and cause an improvement in contraction. We have alluded to this point a couple of times, but just to keep it noted down, an increase in stretch from the increase in preload will lead to an increase in contraction velocity, which makes sense as increase in length leads to increase in tension of muscle fibers. So in 3 dimensions, this relationship between length and muscle fiber tension can be translated to LV volume versus LV pressure. And we should recall that if we fill our ventricle with fluid, we will have some pressure in the ventricle, and that is translated by the end diastolic pressure-volume relationship. Now, the greater LV volume we have, the greater peak systolic pressure we are able to provide. So again, if we have an end diastolic volume, we will have a corresponding peak systolic pressure, and this is directly from that total tension that we were able to obtain from the tension length relationship. So one more time, if we have an end diastolic volume that corresponds to an end diastolic pressure here, that means that we are able to produce a peak systolic pressure at this point. If we have an end diastolic pressure that's from an end diastolic volume over here, we will see that that corresponds to a peak systolic pressure over here. So let's go ahead and reflect this on our pressure-volume loop. If we have a given volume, we can produce a peak systolic pressure, and that is reflected on this line over here, which is also known as the end systolic pressure-volume relationship. Let's rehash what we've talked about for preload. So when we see an increase in preload, we see an increase in fiber tension, and that is dictated by both an increase in active tension as well as an increase in passive tension. That increase in fiber tension leads to an increase in the peak systolic pressure that we're able to provide when the ventricle is contracting. We also see an increase in the fiber shortening velocity or speed, as the greater the tension and the greater the pressure in the contraction, the faster the ventricle is able to contract. We will talk more about fiber shortening velocity when we talk about afterload. It follows then that the greater the preload, the greater we are able to contract our ventricle, and therefore the greater we can increase our stroke volume. That is known as the Frank-Starling mechanism. To draw this relationship, we will include preload on the x-axis, which in this scale is by left ventricular end diastolic pressure, which we will recall from earlier in this presentation is one way to estimate the preload. And on the y-axis, we'll have stroke volume. So the relationship is simply as shown, and if we were to look at a particular point, such as the one that's marked in purple, an increase in preload will lead to a stroke volume in this direction, and a decrease in preload will lead to a decrease in stroke volume in this direction. Now, to review the mechanisms in which we can increase preload, we can increase the venous pressure, which increases venous return to the atrium. We can increase ventricular compliance, which allows for an increase in LV volume without a correspondingly high increase in LV pressure, which is like the balloon versus the rubber bottle that we had talked about earlier. We can also decrease the heart rate, which allows for increased ventricular filling time during diastole. We can improve atrial contraction, allowing for more filling in the ventricle when the atrium is contracting. We can decrease inflow resistance by having functional valves and not stenotic ones like in mitral stenosis. We can increase ionotropy, which allows more of the ventricle to empty during each contraction and thus not have as much volume left over from cycle to cycle. And finally, we can increase outflow resistance and afterload. So by doing this, the ventricle is not able to squeeze as much and thus is not able to empty as much, and thus we have leftover volume from cycle to cycle, which would increase our preload. We'll continue our discussion with afterload. Afterload is defined as the load against which the heart must contract to eject blood, and it can be estimated using this relationship where the letter sigma represents the ventricular wall stress, and wall stress can be thought of as the average tension that individual muscle fibers within the wall must generate to shorten against the developed intraventricular pressure. That is related to the letter P, which is intraventricular pressure, R is the ventricular radius, and H is the wall thickness. This relationship is known as Laplace's law. Now, I have a really hard time remembering this relationship, so what I do is I think that the ventricular wall stress times the wall thickness is proportional to the pressure within the chamber times the radius of the chamber. And then simply by dividing by H, we can get our relationship. So again, the stress in the wall times the thickness of the wall is the same as the pressure in the chamber times the radius in the chamber. So going back to our relationship, if we are to see an increase in intraventricular pressure, we'll see a corresponding increase in ventricular wall stress. If we are to see an increase in ventricular radius, as we might see with ventricular chamber dilation, we would also see an increase in ventricular wall stress. However, if we were to see an increase in wall thickness, as we might see in wall hypertrophy, we would see a decrease in ventricular wall stress, stress being an estimate for afterload. Let's now pretend that our ventricle is a balloon, and that we'll start pushing on this balloon, and that this balloon has an open outflow tract. So this will quickly eject fluid out of the balloon, and it would also cause the balloon to decrease in size pretty rapidly. This is our low afterload example. Now let's consider a state where we have a balloon, but this time put a nozzle on it. And this nozzle will serve as our afterload. So when we try to squeeze on our ventricle, we get increased ventricular wall stress, and we get some fluid out, but not as rapid. And so we see a diminish in size, but also not as rapid. And again, this is our high afterload example. So other changes that we should observe and keep in our minds for later are that we see a decrease in stroke volume with high afterload, and also an increase in end systolic volume with high afterload. So let's examine the velocity of contraction, or the shortening velocity, and we'll go ahead and do this by drawing a graph. So on the x-axis, we'll have afterload, also known as force. On the y-axis, we'll have shortening velocity. And our relationship is drawn in with the x-intercept being known as the maximal isometric force, where load is greater than our ability to overcome it, or the force generating capacity. On the y-axis, we have, of course, our maximum shortening velocity. Now, it should be noted that if we were to increase preload, we would increase the stretch of our myocytes, and increasing our stretch in myocytes, as we will recall, will increase the passive tension and also increase the active tension in our myocytes, and that will increase our ability to shorten the myocytes. The point here is that increases in preload can help offset increases in afterload. Now back to our Frank-Starling mechanism. Recall in the previous slide that I had said that an increase in afterload leads to a corresponding decrease in stroke volume, and that's true at a given preload. Now, if we are to observe this on our diagram, drawn here is a situation where we see an increase in afterload and a subsequent decrease in stroke volume. On the other hand, here is a curve of decreased afterload where stroke volume is increased correspondingly. Now, it may seem that there is a contradiction on this slide, as I've said that an increase in afterload leads to a decrease in stroke volume. However, below, I say that increases in afterload actually increase the preload, and I said before that increases in preload increase stroke volume. However, the truth is that there is a primary and secondary effect to increasing afterload. If you increase afterload, the primary effect is decrease in stroke volume. That decrease in stroke volume leads to an increase in preload, and that increase in preload becomes a secondary, almost compensatory change. I will now demonstrate that on a pressure volume loop. So let's take a scenario where we might increase afterload. For example, we might give somebody a alpha agonist like phenylephrine, and that would increase their afterload. So we had said earlier that this would lead to a decrease in stroke volume. Now let's see what that looks like on the curve. So initially we see diastolic filling as before. However, initially, after we have filled to end diastolic volume, the contraction requires a greater pressure to open the aortic valve. Now, that will lead to contraction at a higher pressure, but at the cost of a decreased stroke volume. So we have a shortened width in stroke volume, and that is reflected here. We also find a increase in end systolic volume. Now, there are secondary effects here, and the secondary effect is that the end systolic volume will add to venous filling. Now, that will actually end up increasing end diastolic volume, and subsequently cause a compensatory increase in stroke volume. So let's observe that on our curve. We will see that the end systolic volume adds to venous filling and thus shifts the end diastolic volume to the right. And following along our curve, we get a contraction to overcome the afterload and subsequent return to our prior end systolic volume and completion of our curve, which gives a compensatory increase in stroke volume, though that compensatory increase is usually not as much as the initial loss in stroke volume. And that completes our discussion on pressure volume curves.